Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Dr. Patel is part of our ECHO community. He's an ID provider at Samaritan Health down in Oregon. And Dr. Patel spent a couple months in Sierra Leone and was kind enough to agree to share a little bit about his experience there. So thank you, Dr. Patel, for agreeing to do this. Looking forward to hearing about it. And why don't you go ahead?
Well, thank you for allowing me to speak. Brian had asked me to speak about my experience in Sierra Leone and talk more about on HIV in Sierra Leone specifically. I'd like to go over a case that will hopefully highlight some of the challenges with dealing with HIV patients over there. And then, if time permits, which I think it will, I'll talk a little bit about my Ebola experience. So, quickly, as many of you know, healthcare in Central Africa and certainly West Africa is pretty abysmal. And this is certainly true for Sierra Leone. Sierra Leone went through a pretty devastating civil war that ended in 2002, and healthcare infrastructure is terrible. As far as healthcare in general, most of the funding is from outside sources. Very little government money is actually spent on providing healthcare to their population. On paper, though, healthcare is theoretically free for children under 5, pregnant and lactating women, or nursing women, and also those who have HIV and TB. And when I say it's free for those for HIV and TB, it means that they're able to get HIV and TB treatment for free, not necessarily comprehensive sort of care. But despite these minimal sort of benefits, the overall effect is that the overall health of the community is poor. Sierra Leone ranks #1 in WHO for their under 5 mortality. You can see their deaths are 182 per 1,000 live births. Life expectancy is 45. So I had the benefit or privilege of working at Port Local Government Hospital, which is a district hospital. There's 13 districts in Sierra Leone. And so this district hospital served as the main reference hospital for the district. And then if there were more complicated cases, they went to the capital, Freetown. And so this hospital more or less serviced a population of about 500,000, about 200. It was a 200-bed hospital. It was the base for their HIV program and TB program. And they had, again, on paper, comprehensive sort of care, pediatric, OB-GYN, general surgery. Overall, 2 doctors managed the whole hospital. One was more or less a general surgeon, and one was right out of medical school. So you can imagine the challenges they face in terms of managing a 200-bed hospital that's supposedly this comprehensive. I'll go over the diagnostic capabilities when we talk about the case. So I love this picture because it sort of summarizes the whole hospital. You know, it's a nice gleaming hospital. In fact, this was a new pediatric ward just before the Ebola epidemic. It's a shell of a building, so it's still nice and clean, but it essentially functioned like this car, which was their district vehicle. And everything in the hospital was more or less like this vehicle, as you see. So how about HIV in Sierra Leone? Well, most of the data I got was through the UNICEF publication in 2013. So Sierra Leone, just so you know, has a population of about 6 million. That's roughly the size of Washington State, I guess. The number of people that's estimated to be living with HIV is about 60,000. And if you go down to the 4th or 5th line, you'll see that give the country a prevalence, at least an adult prevalence, of 1.5%. You know, I think this is thought to be vastly underestimated, and that at least is suggested by some of the prevalence of HIV in antenatal clinics, which can be as high as 3%. So that being said, this is probably a low ball figure, 1.5% infection rate. When we think about who's being infected or how they're being infected, there was an interesting population survey done by the government in 2013. And they don't have a sizable IV drug use community, but they do have a sizable female sex worker community. As you can see, that's at FSW. You know, on the high end, 300,000 female sex workers in a country of 6 million. That to me is just seems a little high, but I can't argue what they collected. And so most of the HIV transmission in this country is thought to be through these female sex workers or through heterosexual contact involving sometimes these female sex workers. So funding for their HIV program is entirely through the Global Fund, which provides 90% of their funding. Antiretrovirals are available. They've been available since 2005. And by some estimates, in 2010, 21% of the adults who had HIV were on antiretroviral therapies. Also, about 50% of women had access to preventative care in terms of preventing maternal fetal transmission. The goal at 2014, according to this 2010 publication, was 100%. I can tell you right now, at least the hospital I was at, that it wasn't being done in terms of the screening and certainly treating pregnant women who have HIV in terms of preventing transmission. So this is Mohammed. Mohammed is their HIV coordinator for Port Local Government Hospital. You know, as best as I could, they have a British-style education system, so as best as I can tell, he completed high school and probably had about an MA level of training. I know that the HIV coordinators all do about 6 months of training, but Mohammed here essentially managed the entire HIV program by himself for the hospital, which covered about 200 people. Each district, again, there's 13 districts in the country, seemed to be managed by one HIV nurse, and that nurse is responsible for managing 10 or 20 Mohammeds. And so, given his limited level of education, he really was doing quite a bit. And it's very algorithmic. It's right out of the WHO guidelines, who they treat and what to treat. And this is what they use. You know, first line therapy, they're using AZT or D4T, 3TC, and efavirenz or nevirapine. So if patients qualify for therapy and they follow the WHO recommendation using CD4 counts, or more often than not, they're using symptoms, then they start treatment. And if they do fail treatment, they don't have genotypes, they don't even have a viral load machine in the whole country, they just empirically switch to a boosted PI, either indinavir or lopinavir. So what has happened overall in terms of healthcare since the Ebola epidemic? Well, MSF, they reported on the overall health in the communities since Ebola hit in the Moyamba district, which was just south of Port Loco. And overall, they saw a 75% decline in admission for children, 70% decrease in attendance to clinics. And it is generally felt more people are dying now from malaria, from childbirth, some of these other diseases than Ebola, even at the height of the epidemic. What's interesting, what Ebola has done in terms of not only neglecting more or less these other illnesses, it's really changed sort of the physician-patient relationship. Physicians now, in some ways, sort of fear patients. And that was definitely palpable when we were there. When I say physicians, I'm talking not only about doctors, but also healthcare providers, nurses. There is really this fear of whether the person that's sitting in front of me with the fever and nausea and vomiting has Ebola. And the people are definitely kept at arm's length. And I think I could understand that. At the hospital I was working with, they lost 5 providers during the height of the epidemic. And then also on the flip side, patients really feared going to healthcare facilities because, one, they didn't want to be labeled as Ebola patients, especially with all the stigma associated with it. But also, the reality is, if they did meet case definition, which was actually quite loose, they'll end up in an Ebola treatment unit for 3 days to get ruled out, even though if they just came for some bleeding. So it really fundamentally changed how providers and patients interacted. As far as HIV and Ebola, we weren't collecting any data. I was unaware of anybody collecting data. And when I did a PubMed search, I really couldn't find anything on how the epidemic is affecting HIV in terms of at the individual level. I would assume HIV patients are more susceptible to complications, and I assumed that they would present a little differently, but I didn't see any data along those lines. What we do know, though, is that HIV patients were not getting care. And so this was actually published in, I think this was the Lancet, just last month, and this was looking at a clinic in Conakry in Guinea, at their HIV clinic. And Guinea is a country just to the north of Sierra Leone. So on the left-hand side, the y-axis, that's the number of patients, the 6,000 that they see in their clinic, and that's that brownish area of the slide. The blue area of the slide is the number of HIV reported cases in the country. And as you can see, the red dotted line is the proportion of HIV patients who defaulted, meaning they didn't come to clinic, they didn't come up to pick up their meds. And as you can see, as the epidemic kind of grew in Guinea, they had up to 42% of their patients not show up to pick up their medications, to come to their clinic and whatnot. And that was definitely true at Port Loco, and in speaking with Mohammed. How they run their clinic there is every month patients come by and pick up their medications, and he said about half of them stopped coming, and that's been that case since the fall, and they're having a hard time reaching these patients and whatnot. So I think we can appreciate the consequences of that. And I think we're going to see consequences. We're going to see more deaths from HIV, and then possibly even transmission, new cases go up. So when we talk about what I had available when we managed HIV patients, and I would imagine this is what most district hospitals had available. We had a rapid HIV test. Theoretically, there were 2 flow cytometers in the country, but I was told they didn't work. We had no viral load capability in the whole country. We did have a rapid malaria test. We had a hemocytometer, which is a very crude way to do hemoglobins, very inaccurate. We had blood typing, a UA, urine pregnancy test. We did have AFB staining because of the TB program that was associated at hospital, but we had no other staining, not a right stain, even a gram stain we didn't even have. And then the glucometer and iStat is what we brought. I worked with an organization called Partners in Health, and that was supplied by Partners in Health. Challenging though, the iStat only worked till 10 a.m. It just got too hot, and then it stopped working. So we had to be very aggressive on who needed iStats in this 200-bed hospital. We could only do about 4 or 5 a day. So this is the first case, and I think it highlights some of the challenges. This was a 25-year-old female who was brought to an Ebola treatment unit by a community health worker. And so what was happening is people weren't coming to get health care, so the government hired this army of community health workers to sort of go out into the community and find Ebola patients. And occasionally they would find, well, not occasionally, often they would find people sick, kind of hiding in their homes, not wanting to come in. Well, this person was brought in, was attended, had a non-focal exam, and then was brought to the Ebola treatment unit. Because they didn't know how long her symptoms had been, she would have to stay there for 72 hours so they can do 2 Ebola tests, which was a PCR-based test, and she did get that. All Ebola patients are empirically treated for malaria. In this case, she was treated with artesunate, which is IV. They're all treated empirically for gram-negative and anaerobic infections, sort of targeting gut microbe transmigration. So she was given ceftriaxone and metronidazole, and she was hydrated. So when her Ebola test became negative, they sort of transferred to Port Local Government Hospital, where I saw her. And upon looking at her, she was well nourished. She was responsive to pain. However, she had really impressive nuchal rigidity. This is, I think, the most impressive Koenigs and Brudzinskis I've seen in a long time. She had thrush, but interestingly, she did not have any lymphadenopathy or hepatosplenomegaly. I think a key point here is, though, she was well nourished. So unfortunately, her rapid test, HIV test, was positive. So thinking about a diagnosis, I don't know, maybe Brian, you want to think of one? I'll put you on the spot.
Worry about cryptomeningitis, probably number 1. TB, probably number 2.
Yeah, you're right on. That's why you're over there and I'm here. And that's exactly right. And you know, when I was trying to look up what are the differential diagnosis of a meningitis in an HIV patient in sub-Saharan Africa, I didn't find anything for a long time. And then this article was recently published in 2014, which was great. This was an article that looked at several studies, and they narrowed it down to 7 to look at the etiology of meningitis in HIV patients. And I'll just cut to the chase. Out of the 7 studies, they had a total of 1,300 HIV patients with meningitis, sort of scattered around sub-Sahara and South Africa, and the vast majority were cryptococcus, right, 52%, followed by TB at 20%, and then pyogenic, which was mostly streptococcal and Neisseria, and then a few others. So, I mean, this was more or less the differential we were working with. I really had no way to, tease out that difference. Remember the limited diagnostic tests. I was able to do a lumbar puncture here, and you can see me doing it. And when I put this slide up, I'm mortified by the lack of sterile technique. There's a needle on the bed. I'm not wearing a mask, but so be it. But I thought maybe an opening pressure would help me. If it was super high, that would maybe argue for cryptococcus. We didn't have a manometer, so I fashioned one out of IV tubing, as you can see there. And long story short, her opening pressure wasn't hugely impressive. It was 32 centimeters. It was abnormal. So really, it didn't help me with my differential. We couldn't do a cell count on the CSF. I did a wet mount, whatever. I'm not sure what that gained me, but I didn't see anything significant. We couldn't do protein or chemistries. We couldn't do cultures. We could do AFB stains, which were negative, but we know those are very insensitive for TB meningitis. Anyways, this patient was treated with ceftriaxone. Remember, she had been already pre-treated with ceftriaxone at the treatment unit, Ebola treatment unit. She wasn't improving. I added chloramphenicol. And then the only antifungal therapy we had available was fluconazole oral. We didn't have amphotericin or flucytosine. So we just put an NG tube in and empirically treated for fluconazole. And then I was in the process as she was progressing was we were going to do an empiric treatment for TB. And unfortunately, though, she died on day 4 at our hospital. And unfortunately, this was kind of a lot of the cases that came out of the Ebola treatment units. People who tested negative, they were essentially not adequately managed for their presenting complaint, whether it be meningitis, pneumonia, strokes, heart attack, bleeding complications of labor. And so they unfortunately succumbed to their disease. That's really what I have in terms of the HIV. Maybe in the last minute, I'll just quickly talk about the Ebola experience. So I ended up going, this is a graph of the cases of Ebola over time. On the left, you can see that was December 2013, the first case in Guinea. And then on the far right, that marches over to March. Sierra Leone is represented in the middle. And I ended up going with Partners in Health more or less in March when the epidemic was waning. And so Sierra Leone is in the middle of the country, and I was in Port Loko, which is in the sort of 10 o'clock area. I think you can see that. So look at Sierra Leone, and right around 10 o'clock is Port Loko. And at that time when I arrived, Port Loko was a hotbed of Ebola in general. One of the most impressive things, at least from my standpoint, that I took away was the training. I had 5 days of training, mostly around infection prevention, donning, doffing. And I liked this training. It was an hour-long lecture on hand washing. And that's Dr. Peter. He's from Kenya. The student or person behind him is a medical student from Sierra Leone. They were our instructors. And I would say this was probably one of the more valuable experiences that I'm taking here is how to properly wash my hands. And maybe I could show you at some later time. So this is Moforke Ebola Treatment Unit. I'm in the green zone, and I'm obviously looking into the red zone. And obviously, it's painted red, and this is actually the suspect ward. Patients are in there, but you kind of get a sense of kind of how the treatment units look like. And I like this slide just to illustrate what we did for these patients. And I'm sorry I don't have a pointer, but at the 12 o'clock position, everybody got malaria treatment, either artesunate amidiaquine or artesunate IV, which is at the 3 o'clock position. They all got Cipro and metronidazole or ceftriaxone and metronidazole for GI prophylaxis. We put an IV in everybody. We gave them as much fluids as they could tolerate. Sometimes, definitely if they were confirmed and they had a lot of what we call wet symptoms, vomiting, diarrhea, we would try to put at least 4 to 6 liters of fluid over the course of a day. They all got vitamin K if they were confirmed, and then we managed their nausea with Zofran. And that's it. That was supportive care for these patients. I think I didn't mention a slide here. I didn't include it, but what I wanted to show was the mortality data. And unfortunately, despite these aggressive supportive measures, we didn't really make a budge on the mortality. We were looking, at least at Moforke, about 50% mortality, even despite the aggressive, quote-unquote, supportive measures. This is the Ebola tree. This is all survivors who leave Moforke. They tie a ribbon around the tree. I wish it was full of more ribbons, but out of the 800 confirmed cases we had over there, about 300 survived, and they left the unit 30 days later. And that's all I have. I think that's the last slide.